All right. I can't see my slides. How can you see my slides? All right. Now you can see my slides. This is what E wave is, correct? The next slide shows E prime septal, E prime lateral. So if I look at my E prime septal is how much? Suppose it's 7. E prime lateral is again 7. 7 plus 7 divided by 2 would be what? 7.
7.
And then divide this 1.34 from 7. That what you will get to E prime average. Clear?
Yes, sir.
So what we get E2 prime average, then we get peak TR jet velocity, and then we get LA volume index. So in diastolic function evaluation, you have to remember these 4 important points when we talk of diastolic function evaluation. Now, do we interpret this diastolic function evaluation into clinical practice? And that's what is the most important part of this presentation is to look for a diastolic function evaluation interpretation in these subset of populations. Let me go back to the slide that talks about diastolic function interpretation by this particular method. And this method was modified in 2016. There was a method which was there in 2009. There was a method which was modified by Sharif Nagy et al. In 2016, talking of a diastolic function evaluation. So what we are talking is 2016 model of a diastolic function evaluation. And that's what I'm, just give me a second. I'm trying to go to that particular format at that level so that you can understand what is mean by interpretation of these pressure into the clinical practice. Now look at this slide. It talks of grade 1, grade 2, grade 3 diastolic disruptions. Correct? Grade 2 means one, grade normal or grade 1 is, what does it mean by? It means or translates into LA pressures of 8 to 10 millimeters of mercury. This is what it translates to. And that's what normal LA pressures are. If we talk of a grade 1, we talk of more than 10 millimeters of LA pressures. If we talk of a grade 2, we talk of 15 to 20. And if we talk of grade 3 to grade 4, we talk of 20 millimeters of LA pressure. Now, my first question is, are you comfortable? How do you look for grade 1, grade 2, grade 3 diastolic dysfunction? Yes or no?
Yes, sir.
Okay. Now, if you calculate diastolic function by this method, then you say my LA pressures are 10, 15 to 20 or more than 20 to 25. Correct? What does it mean by in clinical practice? And that's what I need to explain. Now look at me, my heart is stiff. It is not able to expand or relax. I'm not talking of contraction. I'm talking of expansion. Because for contraction, it has to expand. If my heart is stiff and takes longer time to expand, so what will happen? E will become smaller because the LA pressures are more as compared to the normal person. So E will become smaller and atrial kick will become taller. So E will become smaller, atrial kick will become taller. Now, over a period of time, if my heart becomes more stiff, So the relaxation process will go away completely. E wave becomes still more taller to push, to open the mitral valve, to push the blood from LA to LV, and the atrial kick would be very small. Do you understand this or not?
So
No,
please
sir.
repeat.
We are going to repeat it. Sanjay Mittal was talking what? He was talking of systolic contraction, correct? What I'm talking of? Diastolic relaxation. If I have to relax, LV has to relax. It relax properly so that the blood from LA to LV comes out very effective. Correct? If my LV becomes stiff, my LA pressure build up so that what exactly happens? The initial filling from E wave to A wave, E wave to A wave become reverse where E has to push a small amount of blood and the atria has to contract more to push the blood into the left ventricle. If the stiffness becomes more, E becomes further taller and A becomes smaller. And this is what is reflected by this particular picture. As we grade from grade 1 to grade 3, our EA ratio is less than 1 in grade 1 and grade 2, grade 3 is more than 2 in mitral flow filling patterns. Correct? Now, as this ratio built up, as my LA pressure built up, so what exactly this LA pressure reflects to? These LA pressure reflects to lungs, then to reflect to RV, then to reflect to RA, and then to reflect to IVs. If I've got a very high blood pressure, my diastolic filling to LA to LV will get hampered. And that diastolic function evaluation is being done by looking at EA ratio, E2 prime average, and LA volume index with TR jet velocity. Clear?
Yes, sir.
Okay, go ahead. Ask me the question.
So
Now,
how do
in
you measure the
practice,
isovolumic contraction time and isovolumic relaxation time? The
right,
measurement actually in time.
we do not do in 2016 onwards IVRT, IVCT. Look, I'll show you parameters. This is what you're talking of 2009. This is what is 2016.
Okay.
And this is what is there in 2022. Not touching 2022 for you at all. I cannot teach you something which is about 15 years down the road.
Okay.
What you have been talking about, you have been talking about IVRT, IV, isovolumic relaxation time, dissolution time of mitral flow patterns. No, those are not applicable as on today in clinical practice.
Okay, sir. Okay.
What is applicable today in clinical practice is we look at a normal LV systolic function, that is diastole.
Sir,
Then
one thing.
Wait a minute. Then we have a reduced LV systolic function where the same parameters comes through EA ratio or E velocity, average E2 prime, TR jet velocity, LA volume index. Go ahead. Ask me the question now. What somebody was asking me.
I'm Dr. Shekhar.
Shekhar, go ahead.
Sir, you see that according to the grades, grade 1, 2, 3, 4, so it is the diastolic function is worsening.
Correct.
Now, if we see the EA ratio, now the actually you see that the in grade 4 it is more than 2.
Even grade 3
So
also. Even in grade 3 also. Grade 2 also.
So as the denominator is actually increasing, Because EA ratio A is increasing gradually.
Now, A is reducing, E is increasing. Look, initially, what happens? Normal EA ratio is more than 0.8. It means E is taller, A is smaller. When the first relaxation abnormality happens, we develop reversal of this ratio. That is, E is smaller, A is taller. This is what we get. And then we come to a true same pattern where E becomes taller and A becomes smaller.
Right. Oh, so
And
that's why it is called
continues further.
pseudo-normalization.
So it continues further.
Mhm.
And if we go back to the older time, what we were looking for, what we were doing, and the olden times were, we were looking at this picture where we say, if you happen to see this EA ratio 2:1, do a Valsalva. If it reverts back to this particular phenomena, we used to call pseudo-normal. Correct? If it does not reverts back to this, we used to say restrictive filling patterns.
So initially A goes up and subsequently it goes down.
Correct.
To D.
So
Okay, thank you.
Sir, usually while doing a Valsalva, usually we cannot record that thing change because after doing Valsalva, can you explain the method of Valsalva, how to do?
Janvi is a very simple thing to do, Valsalva. You record a very good imaging quality. Ask the patient to hold a breath in that particular phase.
Forced
Correct?
expiration.
Ask the patient to hold his breath in that particular phase where you are recording your EA ratio. Over a period of time, patient will start struggling to hold his breath. That is what Valsalva is. Tomorrow, very simple, go to 4-chamber view, put a sample volume at mitral valve flow. Wherever you get a perfect sample volume, ask the patient to hold his breath and gradually he'll go to Valsalva automatically.
Okay, sir.
Dr. Venkateshan is snoring, I believe. Clear or not clear? Jill, go ahead.
Sir, why grade 2 is called pseudo-normal? Please repeat, sir.
Grade 2, I'm not talking of a grade 2 now at this level. I don't talk of a pseudo-normal. I touched the topic deliberately because Dr. Shekhar is an old timer like me. And he has not graduated to 2016 till date. So what was exactly happening earlier was, in our previous time when we started looking at echocardiography, we said only 3 types of patterns are present. One is a normal, second is a grade 1, grade 1 is next one, then was grade 2 or grade 3. That's all. In grade 2, if you happen to see this kind of a pattern which appears to be normal, ask the patient to do Valsalva or hold his breath. If this pattern becomes this is known as grade 1 diastolic dysfunction. If this pattern does not change and you look at a deceleration time of less than 130 milliseconds, we used to call them as grade 3 diastolic dysfunction. But with this kind of a pattern, there were many other things. We had to have E to E, like used to look at A wave ratio, A wave versus pulmonic venous flow patterns. Many things we were contributing to that time. IVRT. And those patterns were so difficult to calculate number of times that we were landing up with a possibly wrong reports. Even today also, with my practice for a long time, I say even these parameters of systolic function, when it's normal, it's quite comparable to look for LA filling pressures. When it comes to reduce ejection fraction with this algorithm, there are certain points where we cannot determine the diastolic function. And in 2022, they came out with the elastine algorithm. For elastine, look at the reservoir strain. If the reservoir strain is reduced, definitely this patient is in elevated filling pressures. Now, to explain its importance, before explaining, there are certain other conditions like atrial fibrillation where this pattern does not work. It has got a special algorithm. Sinus tachycardia has got a special algorithm. Hypertrophic cardiomyopathy has got a special algorithm. Restrictive cardiomyopathy and non-cardiac pulmonary hypertension has got a special algorithm. Stenosis and regurgitation has got a separate algorithm. And this is what is utilized in day-to-day practice. At your level, I'm not asking you to learn all of them. I'm just asking you to learn these 5 parameters to calculate your LA pressure and put this LA pressure into this algorithm where normal is normal, grade 1 is mildly elevated, grade 2 is about borderly moderate elevated like 15 to 20 millimeters of mercury, and grade 3 is 20 to 25 millimeters of mercury. What is the importance of calculating this LA filling pressure? Now I'll quote an example for you. Suppose I'm hypertensive. I go and take my blood pressure. My BP is 200 by 110. My heart rate is 110. I look at my diastolic function evaluation. My systolic function is normal. And my diastolic function says my LA pressure is 15 to 20. My question is clear. Hypertensive, 210 by 110 millimeters of mercury. 100 heart rate. Then I'm dyspneic on exertion, walking for a certain distance. Then I do my echo. My LV systolic function is normal, but my diastolic function belongs to grade 2 diastolic dysfunction. Clear?
Yes, sir.
Now, what kind of a medical therapy I will need to control my blood pressure in this scenario? Raise your hand. Just don't jump and answer. Look.
ARBs and diuretics.
No. Wait a minute. I'll ask you. Just raise your hand. Atindra Narayan. Oh, first of all, Dr. Shripat Kode. Shripat, go ahead.
Sir, diuretics and followed by ARBs.
Diuretics followed by ARB. Let's go to the next person. Atindra Narayan.
Sir, we will need medication to decrease left ventricle and diastolic pressure.
Say it again. I'm not able to talk a little louder.
Sir, we need medications to decrease the LVEDP, left ventricular and diastolic pressure.
This is where left ventricular and diastolic pressure. Possibly you joined late in the system. I said when we are looking for a diastolic function evaluation it is synonymous with left ventricular and diastolic pressure, LA pressure, left ventricular filling pressures. They're all synonymous at your level. So I've showed you left ventricular filling pressure, which are elevated 15 to 20. I can come back to you again. Dr. Tanmay, go ahead. What medicine you will prescribe, Dr. Tanmay? So everybody has reduced, they've stopped raising their hands. Only one person said diuretics and ACE inhibitors. Okay, let that person come up again. Why did you say diuretics as ACE inhibitors?
Sir, LA pressures are increased.
Correct. So you want to reduce LA pressure?
Yes.
LA pressure would be reduced by diuretics or ACE inhibitors?
Diuretics.
To some extent, I'll buy your answer, but it'll be reduced by ARBs. How do we assess whether my volume is normal volume, euvolumic, hypervolumic, or volume deficit? This is for Shripat Kore.
So by echocardiography, we can assess that by dilated IVC or.
So I'm looking at dilated IVC or I'm looking at
LA pressure.
pressure.
Okay. Yes.
So why do you want to get that diuretics into this LA pressures? If you look at your echo, if your IVC is dilated, I'll be happy to add diuretics. If my IVC is not dilated, why should we be adding a
Actually, may I respond, Dr. Gupta?
Shekhar, go ahead. Go ahead, Shekhar.
Yes, actually, we have to reduce the, I think, afterload. So by giving the
No. You have to reduce the afterload when you're hypertensive. Control your blood pressure. The first drug which is helpful in both the things are not ARBs, ACE inhibitors. ARB takes 2 weeks to act. So you'll use ACE inhibitor to control your blood pressure, both as well as afterload and preload.
Yes.
Look at your IVC. If it's normal, I'm not going to use diuretics. If it's abnormal or plethoric, I'm going to use diuretics. Look, first is ACE inhibitors, then diuretics, and still if my BP is not controlled, then I'll use my calcium channel blocker. I'm hypertensive. Lasix will come second. Lasix will also come first if my IVC is also dilated. Or my eye pressure are high. Suppose my IVC is 20, collapse is less than 50%, means my RA pressures are 10. And take my word, this is what I do day to day in my clinical practice. Sitting, look, I'm not an interventional cardiologist anymore. I was doing till 2017 and gave it up completely. So that's what exactly I wanted to ask you. And now I'll put the same question in a different sense. Same thing, 210 by systolic blood pressure, heart rate is 100. Now my echo shows normal IVC, normal LA filling pressure, and it says grade 1 diastolic dysfunction. Which antihypertensive you would like to use in this subject? Raise your hand. Venkateshan, go ahead. Tell me, Dr. Venkateshan. First, Dr. Venkateshan. If he is not able to reply, then Dr. Rajesh Tiwari. Wait for some time.
Hello.
Yeah, go ahead,
Hello,
Dr.
sir.
Venkateshan. I'm trying to listen for a long time.
I'll go for beta blockers, sir, since the heart rate is 100.
Yes, you can take beta blocker. You can take calcium channel blocker. Your filling pressures are not. I'm not bothered if you use calcium channel blocker or beta blocker. That's up to your choices.
Yes, sir.
Dr. Tanmay Roy?
Decreasing the rate leads to increase the diastolic filling.
Diastolic filling rate is nothing to do with the diastolic filling. If my diastolic pressures are normal, if I reduce my heart rate from 70 to 60, obviously it's not going to go beyond 60. I'm use calcium channel blockers or beta blockers. The concept is use ACE inhibitors, use calcium channel blocker. If your heart rate is still not controlled, then you use beta blockers. Only one thing I wanted to emphasize with this questions was, look, if I've got an elevated filling pressures, the drug of choice is not anything else, but drug of choice would be the ACE inhibitors. And if ACE inhibitors are not tolerated, obviously we are going to use ARs. Clear or not clear?
Okay. Clear.
All right.
Clear, sir, clear.
Clear. No questions? I'm
Yes, sir,
still
no
open
question.
to questions now, because I want to switch on to something other, which is of
Is it
very
possible to revert back from grade 2 to 1 by giving the
Why not? It always happens. A patient who has come with grade 2, grade 3, comes back to grade 1 or normal LA filling pressure with due course of time with medicines. What exactly you see in your practice? Patient who's breathlessness, he becomes normal with your Medicare. And that's what the magic is of Dr. Shekhar Chakravarti. And that magic, if you add echo to it, will become more magical.
Thank
Okay?
you. Okay.
So let me stop share and then I'll go to something else today in this presentation. I've made this presentation for possibly this day.
Sir, one question.
Go ahead, I'm just trying to find my files. Meanwhile, you can go ahead and ask anything.
Sir, how to decide कि Valsalva manual has to be done or not to be done? In
Very
each
simple.
patient,
If you find tall T wave, small A wave, and your patient is dyspneic, always go for Valsalva manual.
okay. Even sometimes we get normal like that. That may be pseudo
Young
normal.
patients, you'll find a tall T wave, small A wave. That's an exclusion. If a person of 25 years old comes, don't think that he's in diastolic function abnormality.
Yes.
And this is one place, if you'll use all the parameters, then you'll come to know about that he's doing a normal filling pressures.
Rest of them.
Because that's where you'll really realize if you do all the 5 parameters, his LA filling pressure will come out to be normal.
Yes, yes, definitely.
When you have too many slides, this is what exactly happens. Sometimes it becomes very difficult to find out where your slides are. And that's what is, I'll just give me a second because there's no way that I can lose those slides. Yeah, it's this is a very interesting topic. And I've shown this topic to my physicians at least 3 times till date. Can you see my slides now?
Yes, sir.
Yes.
Here's a patient who has got a body surface area of 1.7. He is hypertension. On irregular medicine, BP appears to be uncontrolled, presented for routine echo evaluation on demand of his physician. That patient 200 by 110, 80 pulse, no definite murmurs, chest clear, abdomen soft, liver spleen not palpable, CNS normal. Borderline elevated LDL and serum cholesterols. And look at his echo, ECG. What do you find in this ECG? All of you are top class physician cardiologists and
LV
master
strain.
of ECGs.
Strain pattern is there.
LV strain pattern, sir.
LV strain pattern. Where does this LV strain pattern lies to? 1, AVL and V5, V6. Correct?
Yes, sir.
There's lead 2, 3 AVF, 1, 2, 3, 5, 4, 5. Is this a strain pattern in this patient?
No, sir. Here STV has been elevated in AVR and VR. So it is proximal related obstruction, sir.
AVR is elevated or V1 is elevated?
Sir, both are elevated, AVR and V1.
AVR is elevated.
What is the diagnostic modality of left main disease? AVR or V1?
AVR.
Sir, AVR.
AVR and rest other all have ST depression, all leads.
So what we are looking for ST elevation in AVR, rest all showing a depression. Correct?
Yes, sir.
Now look at the echo. Here is left ventricular hypertrophy. Septum, posterior wall, septum, posterior wall. LS size is 23.5 millimeter per meter square. It means it's dilated more than 22. Then I went on to do a short axis view of this patient. Based on these 2016 guidelines for chamber quantification, this patient classifies to concentric left ventricular hypertrophy. Now look at an echo. Normal, abnormal. Dr. Shekhar, normal, abnormal.
It looks like a concentric hypertrophy.
Correct.
But the movement, there is no such a regional wall motional abnormality. The
Perfect.
papillary muscle
It
are
is
there.
a concentric LVH. We can see the LV wall thickness is 16 millimeter in diastolic over here and almost 12 millimeter over here in posterior wall thickness. And based on this 2016 guidelines, it belongs to concentric LVH. And unfortunately, we could not see any wall motion abnormality. Doppler spectrum pattern, small e or tall e. Why these variable patterns are there? This is what many of you must have seen in your clinical practice. Dr. Javan.
Respiratory
Javan.
variation.
Respiratory variation. Excellent. So which one you will take? Taller or smaller?
The taller A.
Why you take a taller? Why not smaller? So
Go ahead with the Valsalva, sir.
No. What we need in this patient is we need a respiratogram. We'll take whatever is end expiratory. Ask the patient to breathe out, hold his breath, and then you take a aeration. Or you switch on a respiratory gram. Whosoever has a machine, go tomorrow, go to physio. In physio, 2 buttons will open up. One is ECG, second is respiratory. You switch your respiratogram, and whatever is end expiratory, whether it's smaller or taller, you will take this as an evaluation parameters. So patient has got a diastolic function, which is smaller, respiratory movement are seen. And we have taken this because we felt this is end expiratory. And then we've taken a TR jet velocity. And this patient belongs to grade 2 diastolic dysfunction. as per 2009 guidelines. What was the finding? Dilated LA, concentric LVH, normal LV systolic function, grade 2 diastolic dysfunction, mild MR, normal pulmonary artery pressure. Now we went more. What we did in this patient? We went on to do a strain rate imaging. And very beautifully, if you look at the strain rate imaging in this patient, we have cherry on the eyes or apical sparing seen in this patient with minus 17.7% of a GNS, when normal is 20. It means this patient, whose ejection fraction is 66, has got subclinical LV dysfunction. Moreover, apical sparing is suggestive of amyloidosis or deposition disease. We did 2016 guidelines evaluations now. We look at EA ratio, E prime septal, E prime lateral, and LA volume index. LA volume is 26. And now, based on its classification, is this grade 1 diastolic dysfunction with normal LA volume index. Now, look at the same patient with 2019. Our classification belonged to 2000 grade 2 diastolic dysfunction. With 2016 guidelines, our classification belonged to grade 1 with normal volume index. So what is my LA filling pressure? Is 10 only, is not elevated. All right. So what are the changes?
The index was 26, no, sir? Index LA.
Anything more than
LA
34 has to
volume.
be abnormal. 26 is normal. More than 34 is abnormal.
Okay.
So my findings have changed. Blue is normal one, red is the newer. Dilated LA index size is 22. So this remains the same. LVH or concentric LVH with apical sparing, suggestive of some deposition disease, maybe amyloidosis by GLS. Normal LV systolic function or reduced LV systolic function by GLS because of subclinical LV dysfunction. Grade 2 diastolic dysfunction before 2009 guidelines and now 2016, it is a normal filling pressures. Mild MR, normal pulmonary artery pressures. And look at this classification of JAK 21, staging of heart failure. Now this is at one time stage A heart failure. We used to say stage A heart failure. Now it says as at risk for heart failure. Our patient belongs to stage B of pre-heart failures, where it's got a structural heart disease and abnormal cardiac function. What is a structural heart disease in our patient? Dilated LA, concentric LVH. Abnormal cardiac function is poor, reduced GNS. Same patient, same evaluation. When our classification is dramatically changed to pre-heart failure or stage B heart failure. What is the difference between stage B and stage C heart failure? Dr. Shekhar.
Yes.
What is the difference between stage B and stage C?
Stage B, there is a structural heart disease, and stage C is patient is symptomatic.
Correct. Stage B is asymptomatic, stage C is symptomatic. That's all. So our patient is same patient which we evaluated truly by echocardiography is in stage B heart failure. And that is the time to react. If you leave him, he's going to go into stage C heart failure very quickly. Just simple echo. Okay. So I always say, do this echo, it makes a lot of difference. And if you do not treat this patient at this stage, believe my words, he'll go to stage C heart. Let's look at this patient, which is very important in day-to-day practice. Now he's a diabetic. He's a hypertensive. God forbid, he's taking medicine very irregularly, and he's got history of smoking and alcohol, which is very positive. Like everybody smokes, everybody drinks, because money has made everybody very wise and intelligent. And 3 universities of the world, they are helping in their medical treatment. One is Baba Ramdev University, WhatsApp University, and a Google University. So they feel they can correct everything in the world, and that's what this guy was doing over a period of time. 150 by 100, systolic murmuring tricuspid area, congestive heart failure. That's what was present in this patient. Urine albumin 1+, and look at the ECG, which is normal in this subject, and look at the echo. Again, normal LV systolic function. Very good contracting heart. Mild MR. And now look at the classification of E ratio, E prime septal, E prime lateral, TR jet velocity, and LA volume index, which is 38 ml. More than 34. And if I put this all parameters into this classification, this guy belongs to grade 2 diastolic dysfunction, the raised LA volume. It means his LA pressure is almost 15 to 20 millimeters of mercury. No systolic dysfunction. Correct? He's a diabetic hypertensive. He's a smoker and alcoholic. And his ECG is echo. They are normal if you don't calculate a proper diastolic dysfunction. And if you look at this mitral flow pattern, this appears to be normal if you do not calculate the rest of the parameters. Okay. So what does this mean? Grade 2 diastolic dysfunction, raised LA volume. So we went further and we looked at his LV function and LA strain patterns. Now this is LA strain pattern for this patient, which shows LA volume index is minus 65 and reservoir strain is only 29. So average reservoir strain should be 25 to 30. It's just on a borderline. Higher values 39, this is 29, and volume is 34, here is 65 ml. So he belongs to at least higher degree of a diastolic dysfunction, maybe more than grade 2 diastolic dysfunction. GLS, normal in this subject. Same patient, look at the GLS, which is almost 21. Diabetic hypertensive, you look at the RV strain, even RV strain is normal in this patient. And now, what is the final outcome? Normal LV systolic function, normal GLS, normal RV GLS, abnormal RA strain, and grade 2 diastolic dysfunction with raised LA volume index. Is this echo normal? If you don't look at carefully, yes, it is normal. If you look carefully, this is abnormal. What is the abnormality? LA volume index and LA strain in this patient. Clear? I'm not talking of strain at your level. Let's forget about the strain. Let's talk of a diastolic dysfunction with raised LA volumes. And that's what we calculated as 38 ml. Now look at this paper published almost 12 years down the line in JACC. LA volume index relation to long-term clinical outcome in type 2 diabetes. Objective to determine the prognostic importance of LA dilatation in patient of type 2 diabetes with no history of a cardiovascular disease. What is the background? Type 2 DM is associated with development of cardiovascular disease and morphological changes in the heart may appear before symptom rises. And what does it concludes? Increased LA volume was independent and incremental predictor for cardiovascular mortality and morbidity in type 2 diabetes patient with no history of a cardiovascular disease. And look at this classification again in 2021, diabetic cardiomyopathy. This is like, that was 2013. I'm talking about 2021. In diabetics, what is the myocardial dysfunction leading to cardiomyopathy? Enlarged LA. We have an enlarged LA. Impaired myocardial relaxation, which was not there. Elevated LV filling pressure, which was there. Impaired GLS, which was not there. So 4 out of 2, we have enlarged LA and we have elevated filling pressures. It means to say that my patient is at risk of developing stage B heart failure, is developing stage C heart failure at this stage, not because of LV systolic dysfunction. Now he's in stage B heart failure and likely to develop stage C heart failure by diastolic dysfunction abnormality. So anybody who was talking about desolation time, anybody talking about Valsalva measurements, anybody talking of pulmonic venous flow pattern, are we going to fit into all this kind of patterns? No, we are in era of LS 10. Why am I going to go to the LA filling pressures? By the previous ones, you know. My dad used to practice, take a Valsalva, deep inspiration, hold it, and now the patient is tired, he cannot do a Valsalva. And doctor is also having a Valsalva together along with him. There is a Valsalva in this. We have a quantitative measurements now. And this is what is my presentation. And look at this heart failure with preserved ejection fraction. This is a picture of LA strains. Look, the first thing which gets affected is not LA volume index. It's the LA strain which gets affected first. Or the exercise E to E prime ratio. And one paper which is beautifully present recently, what they did, look, they just looked for E to E prime average ratio and they followed up over a period of 10 years. Believe my words, more than 40% mortality was observed in next 10 years with normal LV systolic. So my quest of showing all these slides are, we need to look at a diastolic function, not only in people who are going to reduce LV systolic function, but also in this group of population who has got hypertension, diabetes, metabolic syndrome, and obesity. And one good paper has just published atherosclerotic cardiovascular disease. And in this atherosclerotic cardiovascular disease, if you allow me for a second, I'll just share you what exactly they have said in atherosclerotic cardiovascular disease is, give me a second, I'll just show you that paper because it has really changed the complete scenario of the world. Look at this paper just published a few days back. What this paper says, progression of mild mitral annulus calcification to mitral valve dysfunction and impact on mortality. What does it says that? As we develop a mitral annular calcification, my mitral valve start leaking. And that leakage, despite normal LV systolic function, my airway pressure start building up over a period of time. And these people, they have a very high cumulative mortality and morbidity over a period of time. They just look at the mitral flow patterns. And that's what is in pipeline today. Look at the diabetes, look at the hypertension, look at the the metabolic obesities. And this is one which is making a lot of difference as on clinical practice. So my quest of showing you today about diastolic dysfunction is look at this assessment of diastolic dysfunction in hypertension, diabetes, and obesities. And this is atherosclerotic cardiovascular disease, where we present with atherosclerotic mitral valve or mitral annular calcifications. Any questions before I stop it over here? Because I know like it's too much of a diastology, too much of a systology. We are almost at 11:30 and many of you must be cursing me today. Why? 50% of the people have already left. So let me stop it over here. Any questions? I'll be happy to answer. Remember 5 parameters. Tanmay, go ahead. Remember 5 parameters, EA ratio, E prime septal, E prime lateral, LO1, index, and a TR jet velocity. And believe my words, we do virtually in every subject who walked in our lab.
Sir, can you show your slide, YOLO slide, in your previous lecture in the diastolic dysfunction?
What do you want to see the slides?
Yes, sir. One YOLO slide was there where classification grade 1, 2, 3 was
Okay,
there.
just give me a second. I have to bring back that slide to you.
Yes, sir.
Janvi, you can go and ask the question meanwhile. Go ahead.
Sir, I want to ask, sir, mitral annular calcification will cause leaking of wall, means it is MR or it is something
Both
different?
MR, MS could be atherosclerotic. It could be MR, it could be MS also.
So both will add LA pressure.
100%.
Yes, good.
Janvi, there was one paper about, if I'm correctly, 10 years or 12 years down the line. You know what that person did? He went on to do a stress echocardiography in people presenting with atherosclerotic mitral valves with mitral annular calcifications. You know what was his outcome? Tell me what could be the outcome of that patient study?
No, I'm not able to guess.
50% of the population had a coronary artery disease. Why? Now the question is why? What is calcification? Why the calcium comes to the heart?
Along with atherosclerosis.
Dystrophic calcification.
Inflammation. What do
That
we
leads
look
to
in? What
dystrophic calcification.
What do we look in coronary artery calcification? Why the coronary arteries are calcified? Because we have an inherent inflammation in the coronary arteries. Correct? So
Okay.
when we have an inflammation of the coronary artery and we look at a coronary calcium scoring, if we happen to look at mitral annular calcification or atherosclerotic aortic valve or mitral valve, why can't we have only this in aortic valve and mitral valves? Is it not possible that this calcium has come from along with the coronary arteries? And that's what this person studied over a period of time. And he said, look, this calcium, which is dependent, is seen on these people, is possibly a comorbid factor for coronary artery disease, or these people presenting with raised LA filling pressures I did not show you the slide. Let me just show you that slide. One slide I show you what is the cumulative incidence. Like how does it behave when we have raised LA filling pressures. So this is what slide you are looking for, gentlemen. You can click this slide, save this slide. I'll send you on a
Sir,
WhatsApp.
yes. No, sir, I have a question regarding this slide, sir. This YOLO slide you were showing.
Okay. This slide or previous slide?
No, sir, previous slide, sir.
This one?
Sir, here, yes, sir. Here the first picture where these 40 by 0 hemodynamic changes are there, sir. I have seen in many books this graph, but I have not been able to understand, sir. No one has taught us, sir.
This graph.
If you can please, yes, sir. This graph, this changes gradually. If you can explain, sir, please.
It'll take me another 45 minutes if you agree with me. That's the complete hemodynamics what you're talking about. I don't have a slide of that, but it takes it's a beautiful answer what you're asking for.
Sir, one more question is, we are having one patient with Korea. It is a 18-year boy came with Korea. Probably it is a rheumatic Korea. And
Okay.
how I will look for whether there is a carditis or not. But he was not having tachycardia. But echo was showing mild dilatation. But
Look,
not.
at this stage, if you'll tell me mild dilatation, I'll not be very happy.
But there was pericarditis.
Look, the features of rheumatic fever, there's myocarditis, pericarditis, endocarditis. Correct?
Yes.
If patient has got a pericarditis, he'll have a pericardial effusion. If he's got a myocarditis, he'll have a reduced LV systolic function. If he's got endocarditis, he have got a valvular thickening leading to regurgitations. So if he's 18-year boy, calculate his LV size in Plaque's window just close to mitral leaflet tips and put on a G-score on a website. That will tell you whether this LV size is normal or abnormal.
Once again, sir, about how to. Please, sir. Once. No, this LV size is normal.
That's what I'm saying. You calculate the end diastolic and systolic size and go to the website which shows Z score.
Okay, sir.
I'll give you an answer for that other gentleman. Like, let me just dig out those slides where the graph changes explaining you the sequence of that particular thing.
I will send what echo pictures to your mobile, sir.
Yeah,
Of
you
that
send me.
Okay, sir.
I'll share you on what place you can go to the website to look at the G score. G is a Z score. People call it G score. You can go to the website to look at a G score, and that website is Parameds. Just a second. Okay, you can see my slides over here. Look, this is online Parajet score or G score is, let me just move this cursor down.
Z score.
Z score, parameter Z, and this is online. Suppose your LV size is 41 millimeters, but you have to feed height and weight. Suppose height is 120, weight is 30 kg. So now it will take, let's say, size 40, 30, and then you go for update.
Yes, okay,
40 centimeters, it's not 40 centimeters, 4 centimeters.
Can we see, sir, rheumatic nodule in the mitral
Yes,
plate?
we can see the rheumatic nodule. It's a
Hmm,
beaded kind of an appearance in nodule. So it's not
that was
at the present moment. Look at this. Otherwise, it'll give you peak and mean. It'll give you minus and plus means level and Z score levels over. I don't know why it's not showing at the present moment.
Standard deviation. Z score.
You can go to parametric Z score and that'll give you values for your sizes. And it is all the values for the size. Multiple score levels are present on the website. Z score cardiac structure, Z score pediatric cardiology, public health network, development of Z score, fetal cardiac dimension, cardiac Z score. So many of the scores are present.
Yes.
What we use is a parametric Z score in day-to-day practice.
Okay. Thank you, sir. Thank you.
All right, we'll stop share over here. And I know like there's a lot of class today, 7 o'clock till 12 o'clock in the night, but I wanted to cover up many things so that I have some time to answer your many queries which you have over a period of time. Last question from Dr. Shekhar Chakravarti.
Sir, a practical question, that if I find that the patient has got a grade 2 or grade 3 diastolic dysfunction and I put on a pharmacotherapy, so how frequently I should do a echocardiogram or order the echocardiogram to see the substantial change?
Look, most important thing in this subset of population, look at the clinical aspect of this. If you look at the clinical aspect, their BP has become normal, their pulse rate has become normal, they feel much better, they are less fatigued. It means they have become clinically better. And then after 4 to 6 weeks, you can do an echo. And believe my words, what we do in number of time in this subset of population, when we do a repeat echo after 4 to 6 weeks, we do not charge the same amount of money which we charge in the beginning. We virtually charge 50% of the cost of doing an echo. Because we are not doing the complete echo. We are just looking at certain parameters which were abnormal at that particular moment. And we chart of that. Look at the chart at this time, look at the chart at this time. So 4 to 6 weeks should be the average time.
Okay. Thank you. Thank you, sir.
And it will change your practice. Believe my words, utilize this thing, it will change your practice completely.
So therefore, all hypertensives, diabetic patients and obesity should have an echo.
110%, if you take my word. Systolic and diastolic complete evaluation. I'll share before I close down. We have a very good CDOC center in Delhi. It's a center for diabetes control. It's a renowned center in Delhi. One young lady was getting treatment in center of CDOC from Delhi for diabetes control. She had a very good control of her diabetes. What her problem was, she was having persistent tachycardia. And those people, they did a good amount of echo and they put her on a beta block. Her tachycardia did got controlled, but she became symptomatically worsened. And that's where she came for opinion to our place. And that's what we looked at forward was, they did an echo, but they did an echo for a diastolic function evaluation of 2009 guidelines. And when we did an echo for 2016 guidelines, she was suffering from grade 2 diastolic dysfunction with raised LA volumes. We stopped beta blocker and just increased or added the dose of ACE inhibitors. And believe my word, her tachycardia disappeared. She became much better symptomatically.
Right.
Those she was already on AC, sir. We have
She
increased
was
the
not
dose.
on ACE inhibitor. She was beta blockers.
How can she should not
She was
diabetes?
having tachycardia. So she was
Right,
on
that's
beta blocker.
why, yeah. They thought that it will control the tachycardia.
And that they should take a beta blocker. She became more worsened. You tell me why she became more worsened? What will happen to tachycardia if you make them bradycardic? What will happen to LA filling pressures? They'll become worsened.
It will increase.
Right? And she was getting worsened. And she used to say, it's better to live with tachycardia rather than taking a beta blocker.
Right. Thank you. Thank you very much.
Okay. All right. Good
Thank
night.
you, sir.
Stay safe. And
Good night.
my apologies to spouses. Sorry for
Thank you.
hold it for a long time. Thank you very much. Stay blessed.
Thank you.
We'll
Thank you,
meet
sir.
you next time with another episode of 49th comprehensive course on echocardiography from job.
And sir, question answer? One
After that.
session. Okay, sir. Okay. Thank you, sir.
Okay. Good night. Bye-bye. Enjoy your
Bye.
dinner if you have not taken your dinner.